What's up everybody, Dr. Rossi, and welcome back to the channel. We have a good topic today. I think it's one you're going to be interested in. We've been doing this anxiety theme for the last couple of videos, and I want to continue it because I think there's just so much to unpack. And like I said in the first video, I really feel dissatisfied with the information that I read about when I hear about anxiety disorders and their treatment. So the goal of this is to kind of take all this information and figure out what can we do about these anxiety disorders. Now, of course, when I say abortive treatment for anxiety, the first medication class that comes to mind is, of course, the benzodiazepines, right? Benzodiazepines are going to be the ones that come to mind. And yeah, these medications do exactly what they're supposed to do, of course, in those scenarios, but benzos are possibly the most misunderstood and inappropriately prescribed medication in all of psychiatry. So I'll give you a real life scenario, right? And if you're a doctor long enough, if you practice psychiatry, nurse practitioner, whatever, you're prescribing medication, you're going to run into this. So the patient comes in, they say, hey doctor, I'm very anxious. I can't seem to control it. And by the way, I've been taking Klonopin 2 milligrams a day for the past 20 years. And you're going to say, what the hell is going on here? You're taking 2 milligrams of Klonopin, you should be doing all right when it comes to your anxiety. So if you practice psychiatry long enough, you're going to run into a patient like this. And the goal of today's video is to try to understand where benzos fit into the treatment and how we can prescribe them appropriately and how we can avoid situations like that example of the patient coming in saying, I've been on Klonopin for 20 years at 2 milligrams twice a day. So let's go ahead and crack right into the details. So I want to bring this study up because I think it's an important one. What they did in this particular study was they calculated an effect size for many of the popular medications that are used to treat generalized anxiety disorder. And effect sizes can be thought of as a measure of the effectiveness of the medication, how well does it treat what it's intended to treat, and they kind of fall into different categories. A small effect size will be considered 0.2, a medium effect size 0.5, and a large effect size 0.8 or greater. So let's take a look at the different medications for generalized anxiety disorder, starting with pregabalin. Now, pregabalin has been shown in several studies to be effective for the treatment of generalized anxiety disorder, significantly better than gabapentin actually. So if you're going to choose one of those two to try to augment or as a second or third line, fourth line option for GAD, you're better off going with pregabalin as the effect size is 0.5, indicating it's a medium effect size. Works pretty well. Not great, not the best, but also not terrible. The second one on the list is hydroxyzine, and I've talked about this before. Hydroxyzine is a histamine blocker, right? And this is a medication that actually has an effect size of 0.45 in generalized anxiety disorder, which is considered to be relatively medium. I would say medium effect size at that point. You know, maybe we'll round up there. But either way, it's a decent medication for the treatment of generalized anxiety disorder. The next one is venlafaxine. Now, venlafaxine, of course, is an SNRI, and that only had an effect size of 0.42, so a little bit lower even than hydroxyzine. And then the benzodiazepines come in next at an effect size of 0.38. So you can see that would be considered, for the most part, a low effect size, or small effect size. Now, we have the SSRIs, which come in at 0.36, and then buspirone, or Buspar, which is a medication that is only really approved for generalized anxiety disorder, comes in at a low and very small effect size of 0.17 here. So what we can see here collectively, what we can say is, the medications commonly used to treat generalized anxiety disorder don't work all that well, and collectively the effect size is only about 0.39, which I would consider small. And we can see benzodiazepines fall right at about that 0.38 level. We can now take a trip down memory lane and talk a little bit about how benzodiazepines work. Like, why are they effective? What is the mechanism of action? And what can we take away from this information? You're going to learn something really interesting in this section, so stay tuned. So GABA is the primary inhibitory neurotransmitter in the CNS. Okay, nothing new there, right? Everybody's heard this at least more than once or maybe a million times like I have. So we can think of GABA, I think of GABA like the brakes, right? Like the brakes on your car. It slows everything down. So if I need to hit the brakes on my CNS, right, I'm going to look to modulate GABA. Now, you might be thinking, why not just take GABA, right? They sell GABA over the counter. I mean, you see this all the time, supplement stores, they put GABA in all these supplements, right? So why not just take GABA? And I would say, well, because you're throwing your freaking money away. Do not buy these supplements because GABA itself does not cross the blood-brain barrier and will not get into the central nervous system. It will not do what it's supposed to do. If it were that simple, everybody would just be running around with these GABA supplements like zombies, right? Because they'd be totally messed up and sedated, right? So it doesn't make any sense. It doesn't cross the blood-brain barrier. It can't get into the CNS in order to deliver that anxiolytic effect. Now, the GABA-A receptor itself has 5 subunits, and what happens is activation of these GABA-A receptors is going to cause an influx of chloride and a hyperpolarization of the nerve cell. This is fancy science stuff, basically means that benzodiazepines enhance the actions of GABA, increasing overall inhibition. So that's how we can think about it. Benzodiazepines enhance the activity of the endogenous neurotransmitter GABA, which is the major inhibitory neurotransmitter, the so-called brakes on your central nervous system, and that is what it's going to do. All this talk about benzodiazepines should get us thinking, how often are these medications actually prescribed in the US population? So, of course, I practice medicine in the United States, so I'm always thinking about the US populations. You can apply this, though, you know, in general to other places as well. But again, each country is going to have its own sort of rates. So 3 to 13% of the adult population in the United States is prescribed a benzodiazepine. So this is pretty significant. And if we look and we separate that even further from just adults and we look at the clinical population, say those with MDD, major depressive disorder, or bipolar disorder, 25% of those individuals are prescribed benzodiazepines after the resolution of a clinical episode. So it's interesting that these medications are prescribed after the resolution of a clinical episode, I guess to treat residual anxiety and such that is occurring. So if you, like I do, you pay attention to things, right? You're smart, you think, you're a thinker, and you read the medication insert, the package insert that comes with the medication, what you will find for all the benzodiazepines is a warning. And that warning states that this medication should not be prescribed for more than 2 to 4 weeks. Interesting, right? There's a warning in your medication that says it shouldn't be prescribed for more than 2 to 4 weeks. And that these medications are only indicated for the short-term relief of anxiety symptoms. So it's very interesting, right? That even the medication manufacturers put these warnings in there. And if you want to take it a step further and you say, well, maybe that's just the drug companies being careful because they don't want another opioid epidemic, right? We don't want an opioid epidemic. We want to be careful. We want to tell people, oh, you shouldn't take them too long, right? Well, the FDA trials for safety and efficacy of benzodiazepines only extend out to 4 months. So this was kind of shocking to me that the FDA's trials and safety data only extends out to 4 months. After that, who knows what happens? I have no idea, you have no idea, no one does, right? So who knows what happens? I mean, I guess we kind of do have an idea because like I said, there's people who are on benzos for 20 years that we do have some clinical data to kind of guide us there, but not like real good randomized controlled trial data, like not real, you know, well-designed studies to look at this question. So despite the risk for physical, right, and psychological dependence, tolerance, and withdrawal, benzodiazepines are still prescribed in 10 to 15% of adults for more than 6 to 8 months. So despite all the warnings, the package insert, the FDA's lack of data, right, despite all these things, of course, the risk for psychological, physiological dependence, tolerance, withdrawal, possibly death in really severe cases, 10 to 15% of adults are still prescribed these medications for more than 6 to 8 months, with 5% continuing for up to 8 years. So these are staggering numbers. A substantial amount of people are on benzos. Let's take a look at the specific indications for benzodiazepines as they relate to anxiety disorders. Now, I selected the big ones, the ones that are most commonly prescribed in clinical practice, starting here with clonazepam. So clonazepam, also known as Klonopin, is actually only indicated for the treatment of panic disorder. It is not approved for any other anxiety disorder. It, of course, has been used off-label for other anxiety disorders, and the one that there is some good evidence for is social anxiety disorder. So off-label for social anxiety disorder, the only on-label indication for clonazepam is going to be panic disorder. How about lorazepam, another commonly prescribed one? This is your Ativan, right? If you've seen Z-Dog's video on that, that's very funny, I think. But anyway, lorazepam and diazepam, right? So let's talk about those two. They're both approved for the short-term relief of anxiety symptoms associated with depression and anxiety disorder, whatever the hell that means, right? Whatever that means. So they are approved for the short-term relief of anxiety symptoms associated with depression and anxiety disorder. Whatever this means. It's a little unclear. You can see how people can get caught up in the weeds here of knowing how to prescribe these medications, when to prescribe them, and of course for how long. Now, how about alprazolam? Alprazolam is actually the one that does have approval for generalized anxiety disorder and panic disorder. So it has 2 FDA approvals. It's going to be generalized anxiety disorder and panic disorder. But again, I think that was just like maybe the luck of the draw. Maybe they just like put it put it out there for possible approval for GAD, and it got it, whatever. Because quite honestly, it's the shortest acting and probably one of the ones that's most at risk for abuse. So anyway, as you can see, the benzodiazepines are not approved for many anxiety disorders, and possibly the most abusable one is the only option we have here for GAD. So doctors and patients don't always agree about the risks of benzodiazepine use. Right? There's potential for dependence, like I said, psychological and physiological dependence, as well as tolerance, cognitive disturbances, motor dysfunction, and of course, diversion. Now, my rule when I'm prescribing benzos, and I've said this in previous videos, is that less is more when it comes to both dose and duration of these medications. So remember, less is more. There's limited evidence to support the use or addition of benzodiazepines to the treatment of psychiatric disorders. What we find in the literature is that adults with bipolar disorder who are prescribed long-term benzodiazepines were actually more likely to have relapses. So that's interesting. People with bipolar disorder more likely to relapse on benzos, on chronic benzos. Patients with MDD, on the other hand, were more likely to be prescribed benzos when they had severe anhedonia, which again does not make much sense. In schizophrenia, the addition of benzodiazepines offered no benefit over the antipsychotic itself, except for to increase sedation. So no benefit in the treatment of the actual disorder, schizophrenia. There's a subset of patients, of course, that will benefit from long-term benzodiazepines. We've seen them. We've all seen them if we work long enough, where other medications have failed to help these individuals. There is some evidence to support the long-term use of benzodiazepines in MDD, so reducing overall depressive symptom severity in the first few weeks of treatment, but again, not so good, not exactly what we would want. The appropriateness, of course, of long-term use of benzodiazepines is going to be questionable. The research really cannot guide us here because, like I said, it only extends out for approximately 4 months because there's real severe lack of information. So my rule remains the same, and that is less is more in terms of duration and dose of these medications if you're going to use them. So I want to point out a potential pitfall that you might find yourself in if you're not careful when it comes to prescribing benzodiazepines. So let's take the hypothetical patient here that's been taking alprazolam 1 milligram 3 times a day for the past 15 years. It's the only medication that's ever worked for this person. And when you dig deeper into the history and you learn more about this individual, you find that she has dependent personality traits, she has a very strong external locus of control, and you also find that she's never been depressed, never met criteria for MDD, never met criteria for bipolar disorder, and has never been psychotic. She finds that emotions are intolerable and frequently goes to her medication as a coping strategy. So her main way of coping with distress is to use this medication. She's diagnosed as GAD, persistent depressive disorder, as well as dependent personality. And she, of course, failed trials of SSRIs, SNRIs, adjunctive antipsychotics, including aripiprazole and quetiapine, and of course, multiple forms of psychotherapy. So in this case, clarifying the diagnosis is going to be the key thing, right? Much of what we are seeing in this patient could be called something like pseudo-anxiety. On a superficial level, it seems like an anxiety disorder, right? If we take it at face value, it appears to be an anxiety disorder, but if you dig deeper, you start to find other things that could explain why the person feels the way they do. And you might even say that this is an anxiety disorder that only responds to benzodiazepines. So here, what we actually have, though, in reality, what this situation is, this is an individual with severe stress intolerance. This is a person who has real difficulty dealing with the day-to-day stressors and doesn't really cope with them very effectively. This is an issue essentially of emotional regulation, and on a superficial level is related to generalized anxiety, but not necessarily a generalized anxiety disorder. So these patients, of course, are often vulnerable to seeking medications, and they are also prone to misusing the benzodiazepines because it is the primary way that they cope with stress. Okay guys, so I'm going to hold the video there. I think this is a really good introduction to benzodiazepines and their role in psychiatry, specifically in the treatment of anxiety disorders. And what we should be taking away from this video ultimately is that these medications, while effective in the short term and useful under certain circumstances, do not really have much data to support their use long term, which is something that I've been preaching on this channel for a while. The idea that you should be prescribing these medications for shorter durations and setting time limits with patients and dose limits with patients when you first encounter them and you decide you're going to use a benzodiazepine. So again, the rule of thumb should be that less is more when it comes to duration and dose of benzodiazepines. The second thing you guys should have taken away from this is that if you've been pissing your money away on GABA supplements, they don't cross the blood-brain barrier, they don't get into the CNS, so they're not going to provide those anxiolytic effects. So stop buying them, stop wasting your money if you are buying them. And finally, I think what we could see is that people can sometimes present as having a severe anxiety disorder that's resistant to anything except benzodiazepines. But when you dig a little bit deeper and you really try to understand the patient, you'll start to see that there's other things driving those symptoms and that it's not necessarily a generalized anxiety disorder that you're dealing with. It could be problems of emotional regulation or stress tolerance that this person has, and their primary coping strategy might be to use medication or go to medication every time they feel distressed. So with that said, guys, I'm going to hold it there. If you like the video, if you like the channel, please consider subscribing. It really does help me to continue this thing. And if you have questions, comments, things you want to talk about with benzos, drop them below in the comments section. I'd love to see them. Thanks again, guys. Have a good time.